This evening, we will talk about bronchiolitis. It's defined as a clinical syndrome of respiratory distress. It is seen usually in less than 2 years of age. It's characterized by URI symptoms followed by LRI symptom with inflammation. It results in wheezing and or crackles. This illness lasts about 3 to 4 weeks. It's very important because we need to inform the parents so that they don't get annoyed because the symptoms doesn't subside after you discharge them from the hospital. It's usually caused by a viral infection, RSV being the most common cause, followed by rhinovirus. But it can be caused by other viruses such as parainfluenza, human metapneumovirus, influenza, adenovirus, coronavirus, human barcovirus, and enterovirus. This is the article published in New England Journal of Medicine. As you can see here, 50 to 80% of the time, respiratory syncytial virus is the cause of bronchiolitis. It usually affects from November to April in United States. In temperate climates, it can infect throughout the year. As we mentioned earlier, bronchiolitis typically affects children less than 2 years of age during the fall and winter seasons. Hospitalization for bronchiolitis peak incidence between 2 to 6 months of age. They are the most vulnerable group. They get admitted, but remains a significant cause of respiratory distress for the first 5 years of life. I am going to give global prevalence of bronchiolitis. The bronchiolitis continued to be the leading cause of hospitalization in infants and young children. This is a global prevalence. I'm going to just focus on the cumulative numbers. They have done 0 to 3 months in a different age groups, but I'm going to show you 0 to 5 years. It was published in Lancet 2022. If you can look at the numbers, almost 1.7 million in industrialized countries. In developing countries, 31.5 million children affected. That means about 15 or 16 times higher RSV bronchiolitis been seen in developing countries. But the issue is they have a huge population, so it may be proportionate. But if you look at the death, in industrialized countries, only 900 deaths, while in developing countries is 100,000. That means the death rate is 1,000 times, incidence is 15 to 16 times, but the death is 1,000 times. I think there is lots of work need to be done to reduce the disparity. So what are the risk factors for bronchiolitis? There are Humphrey numbers. Infant of gestation diabetes, prematurity, low birth weight, less than 2 weeks of age, BPD, anatomic defects of lung disease, hemodynamically significant congenital heart disease, immunodeficiency, neurological diseases, absence of breastfeeding, birth date 2 months before or after the start of epidemic. If you're born in the epidemic, high likelihood of getting it, low socioeconomic group, malnutrition, crowded living conditions, passive smoking, and daycare attendance. So if you want to remember 5, this is the best way to go. Congenital heart disease, chronic lung disease of prematurity, history of prematurity, immune deficiency, low concentration of maternal antibodies. These are the high risk factors for RSV disease. How does it happen? The incubation period for bronchiolitis is 4 to 6 days. Then URI symptoms such as fever, congestion, rhinorrhea, irritability, and poor feeding develop. 2 to 3 days after the onset of URI symptoms, 1/3 of the patient have a spread of infection to the LRI, lower respiratory tract. That means 2/3 of the patient, they just have URI, they get better. Well, they potentially can spread the infection to others. So how do these patients' bronchiolitis present? Cough, tachypnea, wheezing, grunting, nasal flaring, and thoracic retractions. If you do an X-ray, you will see hyperinflation of the lung with the trap behind occluder bronchioles. Air trap in the alveoli is absorbed, resulting in localized atelectasis. It causes increased so-called breathing and decline in lung function and causes mismatch of ventilation perfusion, resulting in hypoxemia. In fact, most of the patients will have hypoxemia. These patients have fever of 101 to 102. Since RSV season falls in influenza season, you should be able to differentiate these two. Typically, influenza patients will have a higher grade of fever, like 103, 104 to 105. Okay, other important thing is cough. Cough reflex is absent in neonates, does not mature until after 1 month of age. So most of the kids, 1 month or less, they present as apneic rather than tachypneic. So you have to remember that. These patients will have respiratory distress with increased rate, retractions, wheezing, and crackles. As we mentioned earlier, 1 to 3 days of prior URI symptoms, then LRI symptoms develop. Other important thing to look is diminished oral intake. They can have hypoxemia. Invariably, they will have tachycardia. In children less than 1 month, they present as apnea and retractions, prolonged expiratory phase. They are often very irritable. They will have profuse mucus and nasal secretions, and because of the poor feeding, they often dehydrated. Even though it is easier to pick up RSV bronchiolitis, but one should not miss other possibilities like viral triggered wheezing. It's often, especially in this part of the world, um, sometimes viral triggered wheezing also will have tachypnea and retractions and often not identified and treated as such. Bacterial pneumonia. Bacterial pneumonia can be associated with RSV or it can be the presenting, it may be the primary disease. Pertussis, another thing you should not ignore, especially in those patients who have not had vaccination, or if the child is 2 months or less, they didn't have a chance to get vaccinated. Pertussis is another disease you should not miss. Chronic pulmonary disease, foreign body aspiration, aspiration pneumonia, GERD, gastroesophageal reflux disease, congenital heart disease, heart failure, vascular rings. So you have to keep in mind, in fact, the last season I have seen one patient with congenital heart disease presenting as respiratory distress. And its important thing was this patient had a big VSD, so the child was not, the murmur was not detected early on. And when the patient present with hypoxemia, so what we do typically, we give them oxygen. So that patient had a so big VSD, giving oxygen worsens the situation because it increases the flow into the pulmonary circulation rather than into the systemic circulation. So those things can happen. So do not just go by all of them or just RSV bronchiolitis. It could be congenital heart disease. It could be pertussis. Pathophysiology. The bronchiolitis occurs when a virus infects the terminal bronchiolar epithelial cells. It results in edema, excessive mucus secretion, and sloughed epithelial cells, led to small airway obstruction, airway trapping, and atelectasis. The pathologic changes usually begin 18 to 24 hours after the infection. It results in bronchial cell necrosis, ciliary disruption, and peribronchiolar lymphocytic infiltration. This is the way it works. The virus attaches and infects epithelial cells in the nasal turbinate. That's how it enters. Then nasopharyngeal cells are sloughed and aspirated, carrying RSV into the lower respiratory tract cells in 1/3 of the patient. Then viral application results in epithelial cell sloughing, inflammatory cell infiltration, edema, increased mucus secretion, and impaired ciliary action. These left cells move into the lumen, accelerates viral elimination, but also contributes to obstruction of the airway. The absorption of trapped airway resulting in localized atelectasis. As a result, different symptoms develop. Then eventually it resolves. It's a self-limiting disease. Self-limiting disease. If it improves, go home. If it gets worsened, the patient will end up in ICU. We follow respiratory system score. It's very important to objectively evaluate these patients so that the treatment can be tapered to their need. There are four scoring points we use: 0, 1, 2, 3. And the four parameters we use: respiratory rate, retractions, dyspnea, and auscultation. Based on the age of the patient, for example, if it is less than 2 months, less than 60 is 1 point, more than 70 is 3 points, in between is 2 points. Retractions, subcostal, intercostal, substernal, nasal flaring, any two will get 2 points, one will get 1 point, and all the three will have 3 points. When you have a difficulty feeding, decreased vocalization, agitated, two of the following will have 2 points, one of the following will have 1 point, stops feeding, no vocalization, drowsy, confused, gets 3 points. In auscultation, end expiratory wheeze gets 1 point, expiratory wheeze greater than end expiratory will get 2 points, inspiratory and expiratory will get 3 points. So you add up all the three and come up with the score. If the score is only 1 to 3, you categorize it into mild. Score is 4 to 8, moderate, 9 to 12, severe. The mild category, all these patients probably will have a similar kind of intervention. Assess the work of breathing, nasal suction, and rescore. If the score is less, especially in this, remains 1 to 3 and meets the discharge criteria, discharge home. And when you discharge the patients home, you have to tell them what is the anticipatory guidance, meaning how long the illness will last, how long the cough will last, and when do they have to be concerned, when do they need to bring back, so on and so forth. And the patient score is 4 to 8. Most of them will fall into this category. Assess the work of breathing, do the suction, give oxygen, and rescore them. Sometimes the scoring gets better, they meet the discharge criteria and goes home. On the other hand, if it persists, especially when they still need oxygen, they need to be admitted into the pediatric floor. If the score get worsened, meaning the score of 9 to 12, and that patient end up in ICU. So signs of clinical deteriorations are lethargy, inappropriately low respiratory rate. In fact, higher respiratory rate often seen in children, much worse than adults. It doesn't bother that much, but inappropriately lower respiratory rate definitely a cause of construction. You need to move fast before the patient goes into cardiopulmonary arrest. Apnea needs to be admitted right away and intervene right away. Poor perfusion and deterioration that does not correlate with the day of illness. It can happen early or it can happen later. All these patients need to be on cardiorespiratory monitors, notify MD, and call respiratory therapists as needed. If it is medium, like the score is 5 to 8, you need to do minimum every 2 to 4 hours. You need to do a suction and rescore them and give oxygen if the patient needs, and admit if the patient needs, especially if the patient needs oxygen. And 9 to 12, as I said, this patient needs to go to pediatric ICU. I'm going to explain this one in detail. Just stay with me. When we evaluate the patient with bronchiolitis, 2 months to 2 years is a garden variety of the patient. and make sure the history and exam consistent with the bronchiolitis. We don't have underlying other diseases like cardiac, congenital heart disease, pertussis, etc. Those patients we will follow. We have a set clinical pathway. We follow that one. If you do not have it, establish one so that you can teach the nurses, teach other paramedical staff so that when the patient gets in, they will automatically start doing the stuff as recommended and coached by you. On the other hand, if the patient has underlying congenital heart disease, anatomic airway defects, chronic lung disease, neuromuscular disease, immunodeficiency, we err on the side of overdoing than underdoing because they can run a severe course. These are the therapies not indicated by American Academy of Pediatrics and also subsequent guidelines from other academies. Like routinely giving albuterol, routinely giving epinephrine, hypertonic saline, steroids, and antibiotics not warranted. Routine chest physio is not recommended, chest x-ray and viral studies. But consider chest x-ray in the following circumstances. When there is a persistent focal exam findings, airway complication, worsening condition, and new murmur. In those conditions, chest x-ray needs to be done. So what is the treatment? There is no known treatment shortens course of illness or hasten the resolution of symptoms. What to do? Supportive therapy, relief nasal congestion by suctioning, hydration by oral, NG, IV in their priority. Oral suction, if the child can do it, that is the best way. Otherwise, NG, and if nothing works, IV. Oxygen for hypoxemia, nutrition support is very important in these patients. Fever control often helps. They are less irritable and also less tachypneic and less tachycardic. If you think the child has a severe respiratory distress or if the scoring shows 9 to 12, and start on high flow nasal cannula or intubation depending upon the mental status. All care is dependent on respiratory score. So respiratory score is very important. This is by American Academy of Pediatrics recommendations. These are 2014, almost like 10 years ago. But most of them, as you can see, bronchodilators not recommended, epinephrine not recommended, so on and so forth. I'm going to show what is recommended. So these patients need supplemental oxygen, especially when the saturation is less than 90. And nutrition hydration is very important. It's two important things. Check the pulse ox. If the SAT is less than 90, give oxygen. Nutrition hydration is very important because these patients have poor oral intake and there is higher insensible water loss that patients may need either enteral or parenteral fluids. If the patient is staying in the hospital for more than 3 days, those patients can be considered to be given 3% saline nebulization, apparently, that improves the symptoms. These are from other um, uh, academies, like Australian Academy, United Kingdom, this is United States, Canada, Italy, France, and Spain. Almost they universally agree with American Academy of Pediatric guidelines. I'm going to give the France guideline, which just came 2 years ago, 2023. Just hold on to that one. This one is the old one. The urine microscopy, it's kind of a little different because that is Australian New Zealand guideline says can be considered if the temperature is more than 38. All other guidelines not recommend any of them. And suctioning recommended by all academies, supplemental oxygen recommended by all academies, and monitoring pulse oximetry is also recommended by all academies. The hydration nutrition is universally accepted across and initially oral, nasogastric, then IV. When you do an IV, use isotonic fluids. Supplemental oxygen. When you give a supplemental oxygen, if the patient is 6 weeks or under, keep the SAT more than 92%. If the patient is 6 weeks or older, keep the SAT more than 90%. Oxygen can be supplied via nasal cannula using lowest flow possible. Deeper and self-resolving desaturations may not be clinically meaningful, especially in mild to moderate bronchiolitis. But if the score is very high, most likely they will need continuous oxygen therapy along with pulse ox monitoring. So, what are the important steps you need to consider in suctioning? The suctioning clear the secretion from nares and airway. It's very important because that makes them very irritable. So removing the secretion, they can breathe better and they are less irritable. Also, it induces coughing, which allows child to clear the lower airway secretions. It also reduces orca breathing and improves oral intake. The suction gap should not be lengthier. The recommended is 2 to 4 weeks. Sorry, not 2 to 4 weeks. 2 to 4 hours. So 2 hours in very sick patients. If they are not very sick, 4 hours. But the interval should not be more than 4 hours. That will cause complication. They stay in the hospital lengthier. And also, when you do a suctioning, suction before feeding. Don't do suction after feeding and before sleep. Don't do when the child is sleeping well. When you do a nasal suction, use olive tip catheter. What does that mean? Olive tip catheter means the end of the catheter should not be sharp. Otherwise, whenever you do a suction, it traumatizes the nasal mucosa. So if you do a round tip, that's what olive tip means, round tip, so that it will be gentler on the nasal section, nasal mucosa. Nasopharyngeal suction is not routinely recommended. Sometimes you have to do, but it is not all the time. Nasal edema can be caused by repeated suctioning, so you have to be gentle when you do. Idea is to remove the secretions, not to cause nasal trauma. Always score the patient after the nasal suction so that you know did you do effective suctioning or the suctioning helps or not. And also during this time, family can be trained how to use nasal suction at home because this disease process will last 3 to 4 weeks. So, what to give, NG or IV fluids? The first foremost is oral. If they cannot take oral or if the respiratory distress is so severe, we do not want them to aspirate, so place the NG tube. When you do NG tube, most of the places, including me, we do a continuous feeding. I usually don't do bolus feeding initially. When the things subside, then bolus feeding and remove the NG tube as they improve. When there is a significant coughing, choking, gagging, extreme tachypnea in those patients, IV hydration is warranted. These patients may need a couple of fluid boluses and one maintenance IV fluids. How to assess the worsening condition? When there is an increased secretions, air trapping, atelectasis, hypoxemia, hypercapnia, when there is an acidosis in the blood gas or dehydration due to decreased pure intake. So you need to watch for all those things that may indicate that the kid is getting worsened. So what to do? So I wanted to show how the therapy has been changed over the last 10 years in the United States. I want to start with the blue dots. The blue dots indicates invasive mechanical ventilations in bronchiolitis in PICU in the United States. As you can see, the number of intubated patients remains the same, has not changed in the last 10 years. On the other hand, non-invasive ventilation picked up and gone up, and high flow nasal cannula ventilation gone up significantly higher. So the practice pattern has significantly changed from invasive to non-invasive ventilation. This particular drop is happened during COVID time because people were scared of COVID because high flow nasal cannula non-invasive could disperse COVID virus to other folks. So there was significant drop. Otherwise, Overall, if you see, there is an exponential increase in the usage of high flow nasal cannula. So what will you do? This is the algorithm I like. When the child admitted in the hospital, common supportive care, as we explained before, suctioning, feeding, and giving oxygen. If the patient is hypoxemic, commence low flow oxygen. If the patient respond, titrate and wean oxygen as able. If he doesn't, commence high flow oxygen nasal cannula 2 liters per kilo per minute. I want to show you some people will start with 1 liter. 1 liter does not work. It has been shown 2 liter is much better than 1 liter. 1 liter does not work, 2 liter works. 3 liters doesn't work either. So 2 liter is the optimum amount you can give. And titrate FiO2 to keep the SAT more than 90 or 92. If the patient responds, titrate FiO2 to room air. Once stable in room air, stop high flow, do not titrate flow. Okay, what is stable in room air? In 2018, the randomized controlled trial published in NEJM from Australia and New Zealand, what they did was if the patient is stable for 4 hours, then they stop the high flow. Some people are very not comfortable in stopping high flow at that point. So typically what I do is I go half, then off. That's how I do it. If the patient does not respond according to this article, escalate and consider nasal CPAP. When you do the nasal CPAP, don't start with 5, start with 7, because nasal CPAP is not equivalent to CPAP what you can give through endotracheal tube. My personal preference at that point, I usually go to the RAM cannula ventilation. Please visit RAM cannula ventilation and how to set up RAM cannula ventilation in separate seminar I have done that has been uploaded into the YouTube channel. This is the recent guidelines from France. I wanted to do, this is the, I want to go through their guidelines. The ICU admission criteria for that guideline is when there is an altered mental status, apnea, severe respiratory distress, saturation less than 92 with low flow oxygen, capillary blood gas if it is available, when there is hypercarbia or acidosis. Risk factors we already discussed. Prematurity, RSV identification itself is a risk factor, they call it. Bacterial co-infection, abnormal lung, ultrasound or chest x-ray. Let me say something about the bacterial co-infection. Bacterial co-infection, very common in patient with influenza, very also common in patient with human metapneumovirus. Some reason we do not see bacterial pneumonia associated with the RSV. The most common bacterial infection we see is otitis media. If the patient doesn't respond, always look years for acute otitis media. Treating that one changes the direction. So how do you do? Do not routinely do chest x-ray, capillary blood gas, and sonogram and viral testing. In practice, we do viral testing in all the patients when they walk through the emergency room here in United States. It may not be readily available outside United States. According to these guidelines, not routinely do a PAV, peripheral venous access, and keep the patient in supine position, clinical monitoring for fluid balance, and the PCO2 monitoring, we don't use transcutaneous, we do just saturation monitoring. This is another important thing. And monitor for hyponatremia. Hyponatremia is most common in bronchiolitis. In fact, 1/3 of the patient will have dysnatremia. So watch that one and treat as such. I typically do not restrict the fluids. I'll give regular isotonic fluid, which is defined normal with 20 potassium. That's how I have done. I have done another seminar on how to use IV fluids in hospitalized patients. Please watch that one. It's very useful. And if you wanted to read, I have done a chapter on pediatric hyponatremia in Medscape. Feeding. I recommend gastric as pure feeding. If the patient is so sick, at least place an NG tube and start continuous feeding. If the patient is real sick, place an IV and start hydrating. Always use isotonic. There is no room for less than isotonic fluid in bronchiolitis patient. Ventilator support, we favor, almost all the guidelines favor, and our practice is also non-invasive support. When you do a high flow nasal cannula, according to this guideline, 1.5 to 2 liters per kilo, but we do 2 liters per kilo. I'm going to talk about high flow nasal cannula after this. If you escalate, start CPAP, but start with 7 centimeter water. If the patient doesn't respond, go to NIV, but I typically go high flow nasal cannula to NIV via RAM cannula. And if the patient is so sick, start with mechanical ventilation or escalate. Typically, when the patient is non-invasive, we do not like to sedate because it decreases the respiratory drive, then we run into trouble. Beta-2 agonists are not routinely indicated except if they have significant wheezing. Antibiotics are not routinely indicated. Caffeine is not indicated. Chest physiotherapy is not indicated. Steroids, hypertonic, helium, max sulfate, ribavirin, these medications are not indicated. We used to do ribavirin like many, many years ago, but it has been proven not useful. Few words about heated high flow nasal cannula. Heated high flow nasal cannula is not a standard nasal cannula turned up the high flow. Don't do that one, because if you do that one, what will do is it dry up the nasal secretions and it will affect the mucociliary movement. You will run into trouble. Heated high flow nasal cannula, wherein the gas is heated at up to 37 centigrade with 100% relative humidity. It can deliver room air all the way to 100% FiO2. The flow rate can go up to 60 liters. That is the adult maximum. In this one, the flow rate and the FiO2 can be independently titrated. It works through these following 5 mechanisms. Number 1, it's heated and humidified. It goes with inspiratory demands of the patient. It provides functional residual capacity. It's lighter. Lighter means easy to fit on the face rather than putting a mask. The patient, usually the children do not like that one. It also causes dead space washout. We'll go one by one. What is oxygen dilution? When you give a regular nasal cannula, if you give 1 liter, give 25%. 2 liters, 29%. This is called 4-to-1 rule. Every 1 liter increment, the FiO2 increment is 4 increment. How the oxygen dilution works in patient with high flow nasal cannula. Let's say you give 6 liter nasal cannula, 6 liters regular nasal cannula that give 45%. When you give a regular nasal cannula, what happens? The patient also breathes through the mouth, which is 20 liters of 21% room air. So what do you think? The FiO2 concentration in the trachea. Most likely, it is going to be closer to 21% rather than your intended 45%. On the other hand, if you do the high flow 60 liters at 45%, still the patient can breathe 20 liters, 21%, which is room air. What is the chance of the FiO2 in the trachea? Most likely it is closer to 45%. It is called minimizing oxygen dilution in patient with high flow nasal cannula. It meets the inspiratory demands. Let me explain to you. Normally, you and me, we breathe like 30 to 40 liters. When you give a high flow, this is an adult. When you're giving 2 liters per kilo, you are kind of meeting the inspiratory demand of the patient. Number 2, it decreases oxygen dilution, as I explained before. And also it is lighter. You are not putting the mask on the patient, which the patient hates, especially children. so it's lighter, easier to put on the face and put a dot sticker on both the sides. It doesn't bother them. It increases functional residual capacity, meaning when you increase or when you give 10 liters, these are all adult values, 10 liters, increase the PEEP by 1. If you 6 PEEP it provides. We do not have the equivalent numbers in children, so we do not know. What is dead space washout? When you breathe in 21% oxygen. When you breathe out carbon dioxide. When you do the third time, what do? You breathe in one third of what is being breathed out. But when you do a high flow nasal cannula, you don't breathe the carbon dioxide that was breathed out. That's called dead space washout. So the high flow nasal cannula helps in these 5 different ways. This the article published in, I think, NEJM, randomized trial between high flow oxygen therapy and bronchiolitis. They compared with the standard oxygen therapy. As you can see, the proportion remaining free from treatment failure, the treatment failure was high in standard oxygen therapy when compared to high flow oxygen therapy. So how to give caregiver education is very important. Since the disease process can last for 3 to 4 weeks, when the patient is with you, you need to teach them signs of respiratory distress, when to call primary care provider, when to call emergency department or ambulance, 911 in United States or 108 in India, and how and when to nasal suction, how to maintain hydration, how to give small and frequent feeds most of the time they need, signs of dehydration, anticipatory guidance. Cough can last up to 4 weeks. Do not use over-the-counter cough and cold medicine, hand hygiene, because that's how they transmit the infection from one child to another. This all needs to be accomplished. Not only you treat the patient, also you can contain the infection to that child. Let's move on to immunization, how to protect infants and children. RSV antibody called nirsevimab is available for babies and young children to protect them from severe RSV. And also, the RSV maternal vaccine is available. Pfizer is doing it. Ebrioso is a name. It is given to the pregnant women between 32 to 36 weeks of pregnancy. When to give those shots? Let's start with mom. The RSV vaccine called Ebriso, that may be different in other parts of the world. It's given 32 to 36 weeks of pregnancy. Immunizations are not recommended in non-RSV season in the United States. This is the latest CDC recommendation. Nirsevimab is recommended from October onwards, while RSV vaccine in mom from September onwards. It takes about 2 weeks for the antibodies to kick in. All infants younger than 8 months of age born during RSV season or entering into the RSV season needs to get vaccinated with nirsevimab. Some children 8 to 19 months also needs to be vaccinated. We will go into the detail. Nirsevimab is recommended in infants younger than 8 months of age who were born during or entering into the RSV season, provided the mother did not receive RSV vaccine during pregnancy. If the mother already received RSV vaccine, the child born after 14 days, then you don't need to give nirsevimab. If the mother's RSV vaccination is unknown, then you give nirsevimab or Beyfortus, that is the commercial name here. Or if the infant is born in less than 14 days, mom got the vaccination, if it is less than 14 days, these patients needs to be given nirsevimab. Some infants 8 to 19 months of age, they are at increased risk for RSV disease, should receive nirsevimab. shortly before the start of their second RSV season. It needs to be given during this RSV season or just before as recommended, because the effect lasts only for 5 to 6 months. So what are the patients who need to get when the age is between 8 to 19 months? Children who were born prematurely and have chronic lung disease. Children with severe immunodeficiency, cystic fibrosis, severe disease, Indian and Alaskan Native children. Apparently, in that particular age group, this particular racial group, the RSV infections are severe. And children who should get nirsevimab but have not yet done so may get nirsevimab at any time during RSV season. So these are all indications for immunization between 8 to 19 months of age. How does nirsevimab work? It reduces the risk of severe RSV disease by about 80%. One dose protects the infants for at least 6 months, at least 5 months. That is the length of RSV season. It is not active. It doesn't activate the immune system. It creates a passive immunity. It's a monoclonal antibody. So it's most effective in the weeks right after the dose is given, and slowly it reduces the efficacy. This is the data from Luxembourg from the 2023-2024 season. Europe approved nirsevimab 1 year before United States approved for use. As you can see here, the hospitalization in less than 6 months old prior to nirsevimab and with nirsevimab significantly gone down. Now I have the recent data. It's a systematic review and meta-analysis. It is overwhelmingly positive. This side favors nirsevimab. It reduces the hospitalization, reduces the ICU admission, reduces the lower respiratory tract infection. And if you look at the p-values are significantly better. So nirsevimab needs to be given. It reduces hospitalization, reduces ICU admission. I am sure it reduces the death. Let's move on to vaccine for adults aged 50 and over. Last year, it used to be 60 and over. CDC revised the guidelines this year, 50 and over. There are 3 RSV vaccines licensed by US FDA for the use in adults. All adults aged 75 and older should get RSV vaccination. One difference between RSV vaccination and influenza vaccination needs to be given every year. RSV vaccination, 1 vaccine is enough. In those patients who are 50 to 74, if they have a severe risk, increased risk of severe disease, then they can get. As I mentioned earlier, there are GSK's RXV, Moderna's Remdesivir, Pfizer's Ebrisval. These are the 3 available for adults. They activate the immune response, not like nirsevimab. Nirsevimab is a passive immunization. The CDC recommends RSV vaccination for all adults above 75. For adults 50 to 74, if they have chronic heart or lung disease, if they have a weakened immune system, certain other medical conditions like severe obesity, severe diabetes, those who are living in nursing home or their long-term care facility, those patients need to be given if the age is 50 to 74. As I mentioned earlier, RSV vaccine is just 1 single dose. It need not to be given every year. So what is the efficacy? GSK's RXV, it provides protection up to 2 years. Those are the data we have. Ebrisval, it protects up to 2 years. Moderna's up to 1.5 years. The reason being they have been recently approved for adult use. 2023, RXV and Ebrisval and the Remdesivir in 2024. So we don't have enough data to say it has a long lasting protection. Only the time can tell. This concludes the talk on bronchiolitis.